Hello and welcome to our Longevity Coach podcast. And we will talk today about obesity, a systemic disease, not just excess weight. And together with me today is Dr. Alla, our functional and regenerative medicine doctor, and also a certified specialist by Canadian Board of Weight Loss.
Hello everyone.
Obesity has quietly become one of the biggest medical challenges of our time. Not because people look a certain way, but because underneath excess weight, there is almost always a cascade of metabolic dysfunction, type 2 diabetes, cardiovascular disease, hormonal imbalance, accelerated aging. And what we now understand is that excess weight isn't the problem itself, it's a symptom, a signal that metabolism has lost its balance. We are going to dig into what's really going on when the patient's weight won't budge and what we can actually do about it. So let's start with something that sounds simple but really isn't. How do we actually determine if the patient has obesity?
Right, and this is where most people get it wrong. We're not just looking at the scale. BMI gives us a starting point, 30 and above, but it tells you very little on its own. We look at the weight circumstances, over 88 centimeters in women and over 110 in men, because that's where visceral fat tends to accumulate. We assess body fat percentage, we look for signs of insulin resistance, and we check for sarcopenic obesity, which is one of the most diseased patterns you can see clinically.
Sarcopenic obesity, that's one where the person looks relatively slim, but their metabolic picture is a disaster.
Exactly. Normal weight on the outside, high visceral fat on the inside. And it is arguably more dangerous than classic obesity because it flies completely under the radar and the muscle mass is low, mitochondrial function is compromised, hormonal synthesis suffers. So these patterns come in looking fine and the numbers tell a completely different story.
So essentially, if we are honest about it, most sedentary urban adults are somewhere on this risk spectrum.
Unfortunately, yes. Chronic stress, disrupted sleep, gut dysbiosis, insulin resistance, PCOS, perimenopause, these are everyday clinical realities now. And the common thread is a metabolic load that the body can no longer compensate for.
Which brings us to the question. I hear patients ask all the time, and honestly, some physicians still believe the obesity is just overeating and lack of willpower.
No, and I think we need to say that clearly and without apology. Modern medicine classifies obesity as a chronic metabolic disease. What drives it? Insulin resistance, chronic low-grade inflammation, hormonal dysregulation, and of course, leptin resistance. A patient can be eating very little and still gaining weight, and that's not a character flaw, that's a broken metabolic feedback loop.
For a long time, the dominant model was simple: calories in, calories out, and it made intuitive sense. But it doesn't hold up when you actually look at what metabolism does.
60 to 75% of daily energy expenditure has nothing to do with exercise or food digestion. It is the basal metabolic rate, brain function, cardiac activity, thermoregulation, and liver detoxification, cellular repair. But when metabolism slows down because of chronic stress or hormonal dysregulation, the body starts storing fat even on a moderate intake. The math stops working because the denominator changed.
And the denominator nobody talks about enough is adipose tissue itself, because it's not inert.
Not at all. Adipose tissue is an active endocrine organ. It secretes inflammatory cytokines, it drives insulin resistance, and it pushes cortisol up. It amplifies oxidative stress. The body shifts into a state of chronic systemic inflammation, and then everything downstream suffers.
We talk about different fat deposits: subcutaneous, visceral, ectopic in the liver and heart, brown fat, which is actually metabolically beneficial. Which one should clinicians be most concerned about?
Visceral fat, without question. It surrounds the organs, it has direct portal access to the liver, and is the most metabolically active in the damaging sense, constantly releasing inflammatory molecules. And it's the depot most strongly linked to type 2 diabetes, cardiovascular disorders, fatty liver, hormonal chaos. And body fat percentage is, in my view, one of the most underutilized clinical markers we have.
What are the primary drivers you see today? Because this is clearly not just a food problem.
Of course, ultra-processed food and excess refined carbohydrates are part of it. And but chronic stress, sleep deprivation, microbiome imbalance, endocrine disruptors, toxic load, age-related metabolic changes, all of these contribute and they interact. Obesity is never monocausal, it's always convergence.
And let's talk about stress and sleep specifically, because I think clinicians often treat them as soft factors.
They are not soft at all. Chronic stress drivers cortisol up, and elevated cortisol does Three things that are directly relevant here. It pushes fat into the abdominal region, it creates cravings for sugar and high-density food, and it breaks down muscle tissue. So meanwhile, even partial sleep deprivation shifts the hunger hormone ghrelin goes up, leptin goes down, and the body is literally in a state that favors fat accumulation regardless of what the patient eats.
Yes, so sleep and stress management aren't lifestyle advices, they are real metabolic interventions.
And that's exactly how I frame it with a colleague. If a patient wants to lose weight and we are not addressing sleep and nervous system recovery, we are missing the biggest layer.
Can anyone lose weight on diet alone?
Short term, yes. Long term, not sustainably, and not without addressing the root cause. If the inflammation is still running, if hormones are out of balance, if the gut microbiome is dysbiotic, the weight comes back every time.
So, Dr. Alla, what does a real protocol look like?
It starts with restoring metabolic function, not just cutting calories. We normalize hormones, we reduce the inflammatory burden, we address sleep and stress, we work on gut health, and critically, we protect muscle mass throughout. And when the body stops feeling under threat, weight regulation tends to normalize on its own. It's not a fight against the body, it is an alignment with how the body actually works.
Obesity is not a willpower problem. It's a metabolic stress signal. And the moment we start treating it that way, tracing it back to its root causes, we stop chasing symptoms and start doing medicine. That's what this conversation is about. So thank you, Dr. Alla, for this amazing conversation. And also, dear colleagues, we are welcoming you to our longevity code course, where you can learn everything about obesity at our obesity module.